You think a doctor reviewed your case and decided that treatment wasn't necessary. They didn't. In most prior authorization denials, no physician with your specialty, your diagnosis, or sometimes any clinical training at all made that call. What made it was a proprietary software tool, a checklist built by your insurer, and a financial incentive that has nothing to do with your health. The phrase, not medically necessary, sounds clinical. It sounds like a medical opinion from someone who read your chart. It isn't. It's a business decision wrapped in medical language, and it is specifically designed to be hard to fight. This video is for educational purposes only and is not medical or legal advice. But what you're about to hear is information your insurer counts on you never finding out. And here's the part that makes this urgent. If you've already been denied, you have a window to fight back. In most states, that window is 30 days. Under federal ERISA rules, it can be as long as 180 days, but only if you know to invoke it. Most people don't. They read the denial letter, assume the system has spoken, and give up. That's exactly what the insurer is counting on. So let's pull back the curtain on how this actually works. Prior authorization, or prior auth, is the process where your insurer requires your doctor to get approval before you receive a treatment, medication, or procedure. Sounds reasonable on the surface. In practice, it has become a systematic denial engine. According to the American Medical Association, physicians submit an average of 45 prior authorization requests per week. That number alone tells you this isn't a targeted safety check. It's a volume operation. The entity making the denial decision is called a Utilization Review Organization, or UR organization. Your insurer either runs one internally or contracts one out. Their job, officially, is to evaluate whether a requested treatment meets the standard of medical necessity. But here's the thing that most people never ask. Whose standard? Not your doctors, not the FDA's, not a medical boards, your insurers. And this is where the mechanism gets specific, because the way they define medical necessity is not random. Insurers use proprietary clinical criteria tools. The two dominant ones in the American market are called InterQual, owned by Change Healthcare, and MCG, formerly known as Milliman Care Guidelines. These are not government standards. They are not peer-reviewed public documents. They are proprietary products that insurers license, and they are not required to show them to you or your doctor in most cases. Your physician recommends a treatment based on years of training and direct examination. The UR reviewer checks it against a checklist that your doctor has never seen. Think about what that actually means. Has something like this happened to you? A treatment your doctor recommended got denied, and you had no idea why or how to push back. Tell me what happened in the comments. I read them, and your situation might be the next video on this channel. Now, the financial incentive piece. This is where it stops being a policy debate and becomes something more uncomfortable. Utilization review organizations, when they're internal to the insurer, save the insurer money every time they issue a denial. Some UR companies that operate as third-party contractors have faced scrutiny and litigation over compensation structures that critics argue reward denial volume. The Department of Labor, which oversees ERISA plans, and state insurance commissioners have both opened investigations into UR practices over the past decade. The system isn't neutral. It has a rooting interest. And then there's the automation layer, which has accelerated this entire problem. In recent years, major insurers have begun using algorithmic tools to process prior auth requests at scale. A ProPublica and congressional investigation found that at one major insurer, a medical director was approving or denying claims at a rate that worked out to roughly 1.5 seconds per case. 1.5 seconds. Not enough time to read a patient's name, let alone their medical history. That's not a medical review. That's a sorting algorithm with a rubber stamp. And here's our take. The prior authorization system as it currently operates is not a clinical safeguard. It is a financial filter dressed in medical language. The phrase not medically necessary is a legal liability shield, not a diagnosis. If you want to understand every lever insurers use to delay and deny, and more importantly, how courts have started pushing back, that's what we break down here every week. Subscribe, and you won't miss the next one. So what are your actual rights? This is the part most people never get to because they give up after the first denial letter. Let's be specific. Under the Affordable Care Act, every health plan sold on the individual or small group market must provide you with an internal appeal, right? That means you can formally challenge the denial inside the insurance company. The insurer then has to have a different reviewer, one who was not involved in the original decision. Look at your case. You also have the right to receive a written explanation of the denial, including the specific clinical criteria used. That's critical because that document is your roadmap for the appeal. Beyond the internal appeal, most states give you access to an independent medical review, or IMR. This is where a neutral board-certified physician in the relevant specialty with no financial relationship to your insurer reviews your case. In California, for example, the Department of Managed Healthcare runs this process, and insurers are bound by the outcome. Multiple states have similar programs. Studies of state IMR programs have found that patients win these reviews at rates ranging from 30 to over 50%, depending on the state and condition. 30 to 50% for people who were told their care wasn't necessary. If your coverage is through an employer-sponsored plan, you're likely under ERISA, the Employee Retirement Income Security Act. ERISA Section 503 gives you specific appeal rights, and it requires the plan to provide you with all documents relevant to your claim, at no charge if you request them. That includes the clinical criteria used to deny you, the ones they normally won't show anyone. Request that document in writing, by certified mail. The moment you do, you've changed the legal landscape of your appeal. And there's one more layer here that connects two things people don't usually put together. The URAC, which is the accreditation body for utilization review organizations, sets standards that UR reviewers are supposed to follow, including the requirement that a denial for medical necessity must be made by a clinician in the same specialty as the treating physician. If your oncologist recommended a cancer treatment and the denial came from a general practitioner or a non-physician reviewer, that is a URAC standards violation. Document it. Name it in your appeal. It changes the tone of every conversation that follows. Now let's talk about the mistakes that kill appeals before they have a chance. Because knowing your rights means nothing if you hand your insurer an easy win. Mistake 1, sending a generic appeal letter. Most people write something like, "I believe this treatment is necessary, and I am requesting reconsideration." That letter gets denied in under a week. Why? Because it doesn't engage the insurer's own criteria. Remember, they denied you based on a specific checklist, InterQual or MCG. Your appeal needs to address each criterion they flagged point by point with clinical evidence. Ask your doctor to write a letter of medical necessity that uses the specific language from the denial, not just their own clinical notes. That's the document that makes reviewers slow down. Mistake 2, missing the deadline. And this one is brutal because the deadlines vary by plan type and state. Under the ACA, for urgent care denials, you typically have 72 hours to request an expedited internal appeal. For non-urgent cases, it's often 30 days from the denial date. Under ERISA, you may have up to 180 days, but only if your plan document specifies that. Read your denial letter the day it arrives. Identify the appeal deadline on that day. Calendar it immediately. The insurer will not remind you. Before I tell you the third mistake, I want to hear from you. What's been the biggest insurance or healthcare denial issue you've personally run into? Drop it in the comments below. Your situation might literally be the next video on this channel, and other people in that same situation need to hear that they're not alone. Mistake 3, stopping at the internal appeal. This is the one that costs people the most because winning the internal appeal is actually harder than most people realize. Insurers have a financial incentive to uphold their own denials. Here's the counterintuitive truth. The independent medical review process, the external one run by your state or a neutral body, is often where patients actually win. Research on California's IMR program found that patients prevailed in roughly 42% of external reviews. 42%. Those are not bad odds for a process most people don't even know exists. File the internal appeal, yes, but prepare your external IMR request at the same time. Don't wait to see how the internal one goes. Time is working against you. So here's where this lands. Not medically necessary is not a clinical conclusion. It is a legal phrase generated by a proprietary algorithm or a checklist issued by someone who may have spent less time on your case than it takes to read this sentence. But it is not the end of the road. You have federal rights under the ACA and ERISA. You have state-level external review rights. You have the right to the criteria document they used against you. And when you use those tools in the right order, you have a real chance of reversing that denial. The system is designed to outlast you. Most people let it. You don't have to. If you want to go deeper, we have a video already up on what happens when insurers delay instead of deny outright, the bad faith delay tactics that accomplish the same result without ever saying no. It's linked right now. Watch that next, because delay and denial are two sides of the same strategy. And if this video would have helped you when you needed it most, subscribe! Every week, we break down what insurance companies and corporations count on you not knowing. In plain English, no law degree required.